Section 1. Anatomy of avascular necrosis.
Let's look at this like a medical mystery centered around vascular vulnerability. Fracture of which bone classically results in the complication of avascular necrosis? A. The shaft of the humerus. B. The sesamoid bones. C. The neck of the femur. D. The clavicle. Or E. The neck of the fibula.
If you guessed C, the neck of the femur, you hit the nail on the head. But why? Well, avascular necrosis, or AVN, is essentially bone death caused by ischemia. Picture the deep arterial red blood supply of the extracapsular vascular ring. Ascending branches travel right beneath the synovial membrane as retinacular arteries. When you get an intracapsular fracture, it physically snaps this delicate subsynovial network, completely starving the femoral head of its blood supply. So the crucial point is, you absolutely need to know these classic AVN eponyms for your exams. Think of these as high-value pearl drops. We've got Kienbeck's disease in the lunate bone, Freiberg's in the second metatarsal head, Kohler's in the navicular bone, and Preiser's disease involving the carpal scaphoid bone. Definitely lock those into your memory.
Section 2. The Garden Classification Scale. All right, let's look at a 45-year-old male who suffers a complete femoral neck fracture with partial dislocation. This is a Garden Stage 3 injury. Based on that trabecular disruption, what's the most common complication? A. AVN. B. Malunion. C. Osteomyelitis. D. Non-union. Or E. Volkmann's ischemia contracture.
The answer is A. Avascular necrosis. Now, what's really interesting about this slide is how the displacement perfectly dictates the risk. Stage 1 is incomplete and stable. Stage 2 is complete but non-displaced. But look at Stage 3. It's a complete fracture with partial displacement causing a varus shift. Because those fragments are partially opposed but shifted out of place, they physically tear the retinacular vessels, jacking up that AVN risk to around 30%. And Stage 4, that's fully displaced, so the risk is very high.
Section 3. Fixing the young adult.
Let's bring back that high-stakes case from the very beginning. Our 29-year-old female with the non-displaced intracapsular fracture. The definitive treatment for her? It's E, the cannulated screw. Since she's well under 60, our absolute primary goal is preserving her native femoral head. Using 3 parallel cannulated screws, usually placed in an inverted triangle, provides mechanical stability while protecting what's left of the blood supply to encourage primary bone healing. We definitely want to avoid arthropathy here to prevent future implant wear over her long lifetime.
Now let's contrast that. We have a 37-year-old male, but this time it's a stable, non-displaced intertrochanteric fracture. Notice that this is an extracapsular injury. What's our best treatment here? A. Cannulated screw. B. Closed reduction. C. IM nail. D. Dynamic hip screw. Or E. Plate and screw.
And this brilliantly illustrates the biomechanical shift. The correct answer is D, the dynamic hip screw, or DHS. Because the fracture is extracapsular, that precious retinacular blood supply is entirely preserved, meaning a much lower AVN risk. The DHS is the gold standard for this. Its sliding lag screw lets the fracture fragments collapse and dynamically compress along a controlled axis when the patient bears weight. It essentially uses mechanical stress to promote stable bone healing.
Section 4. Geriatric arthroplasty triage.
Okay, let's shift gears to a much more frail geriatric profile. We have an 83-year-old bedridden male with chronic kidney disease. He presents with a displaced intracapsular femoral neck fracture. What's the best suited treatment? A. Plate and screw. B. Hemiarthroplasty. C. Intramedullary nailing. D. External fixator. Or E. Total hip replacement. Keep his low functional demand and severe comorbidities in mind.
This brings us to the ultimate orthopedic dividing line, age-driven reconstructive triage. For young patients under 60, we prioritize native head preservation with rigid internal fixation. But for the elderly, over 60, with displaced fractures, the philosophy completely flips. We prioritize joint replacement, or arthroplasty, to minimize the massive risks of non-union and AVN that come with trying to fix osteoporotic bone.
So solving our 83-year-old's case, the answer is B. Hemiarthroplasty, specifically something like an Austin Moore. Why not a total hip replacement? Well, a THR is strictly reserved for high-demand, independently mobile patients because it carries risks of longer operative times and future dislocation. Our patient is frail and bedridden. A unipolar hemiarthroplasty replaces the fractured head but leaves his native socket completely intact.
This means a shorter surgery and early mobilization, which is absolutely vital for someone in his condition.
Section 5. Pathological fractures and traction.
Now let's introduce a complex oncological variable. A 60-year-old male with lymphoma is currently undergoing radiotherapy. He sustains a pathological intracapsular femoral neck fracture. What's the best management here? A. DHS, B. X-fix, C. Arthroplasty, D. Plate and screw, or E. IM nail. Think about the paradox of trying to mechanically reconstruct irradiated bone.
The correct answer is C, arthroplasty. Here's the deal. Pathological fractures in the femoral neck just do not heal reliably with standard internal fixation. The tumor, combined with the radiotherapy, totally impairs osteoblast activity. So, immediate joint replacement is required. And here's a crucial exam pearl. Under the Myers scoring system, a cumulative score of 8 or more demands urgent prophylactic structural stabilization via arthroplasty.
Now I want you to look at this number. 5 kilograms. That is the strict maximum physiological weight limit permitted when you're using skin traction, like Buck's traction, for short-term stabilization. If you apply loads heavier than 5 kilos, you generate excessive shear forces, and that predictably leads to a whole host of problems: friction blisters, skin tears, superficial necrosis, and even peripheral nerve compression. 5 kilos is the absolute limit, for sure.
Let's move to and see how this builds in our final section. Section 6, stress and distal fractures.
Let's do a rapid-fire question about repetitive, submaximal mechanical loading. Which of the following bones is a common site for stress fractures? A. Clavicle, B. Scapula, C. Tibia, D. Fibula, or E. Sacrum?
The correct answer is C, the tibia. It's the most common site because of microfractures that develop in the trabecular matrix when repetitive loading just totally overwhelms the osteoclastic and osteoblastic cycles. But consider this before we wrap up. If an 18-year-old has a stable, extra-articular distal femur fracture that's treated with a simple cast, what do you think happens when that fracture line crosses into the joint space? Think about those articular integrity thresholds. We'll have to save that mystery for next time. Thanks for joining me for this explainer.